My name is Magdalena Skowronska, and I wanted to extend my welcome to the student body as well as the faculty that are watching this today. I'm doing my DNP scholarly oral presentation on implementing post-discharge calls in urgent care in order to increase compliance and satisfaction. I wanted to include my committee members. My chair is Dr. Elby, and my community member is Dr. L. Burpee. Introductions. Patient often visits the urgent care for simple or acute disease process with no follow-up care or a way to ensure that they are complying with the prescribed medications or plan of care. Patient satisfaction has been a concern for quite some time, as most urgent care centers do not check the patient's post-visit to see if anything else could have been done to enhance their visit. Thus far, there has been an underdevelopment of measures in the literature regarding timeliness, efficiency, patient-centered care, and equality of care. Abstract. So this is a little busy slide, but I promise that it will be easy to go through. It was just the best way to compact a little bit of information to one slide. So the purpose of my presentation was to increase patient compliance via post-discharge phone calls between 24 to 72 hours, so within 3 days. The background, like mentioned before, is that the urgent care is a very busy place, does not always allow for good discharge instructions, and up until now there has been no standardized tool to use in the urgent care to assess compliance and satisfaction. Sometimes the discharge instructions can be given by me, sometimes they can be given by my ancillary staff. So not all questions are always answered properly or are not always answered in a timely manner. The patient is, rushed. Most of our patients are a little older, so they need a little bit more time. My methods consist of a correlation quantitative DNP project that used a retrospective chart review from 120 patients between the ages of 18 and 89, meeting the inclusion criteria as outlined in the study. And we'll go through that later on. So Appendix A is on the next slide, and I use that as my kind of template of how to call the patient, introduce myself and such. The results, I set a 75% bar where I said, 75% the patient will be satisfied and compliant. I actually received over 90% satisfaction and compliance in the study. The study was statistically significant in that the p-value was less than 0.0001, and that was less than the significance level of 0.05. The conclusion is that the research did show that, in fact, post-discharge calls are important in the patient's overall care in order to provide the whole patient experience and include their compliance and satisfaction during their visit. So this is the appendix that I spoke about. I used this for three tries, 3 phone calls. For the participant's ID, I would put the patient's initials. Let's say it's Mary Smith, so MS. She was the first person I called, so MS1. So that would be her ID. So hello, Ms. Smith. My name is Magdalena. I was your nurse practitioner. And then we would go through the call. I would offer if there was another family member, if they were hard of hearing. I would offer if they had a case manager that wanted to ask any questions before we started the call. But they were allowed 3 calls in the time that they wanted. So question 1 that they were asked was, are you satisfied with the care you received at the urgent care? It was an either yes or no question. And question 2 said, are you complying with the medication and instructions you received? Again, yes or no question. Very easy questions. The second one sometimes took a little bit longer because it might have extended to, I feel better, should I stop the antibiotic? And of course, no, you should finish the whole entire antibiotic. But that in itself should have been said during the visit. You should finish all antibiotics before before you feel better and whatnot. So again, question 2 sometimes took a little longer, but ultimately it was either a yes or a no. So the aims of this project was to increase patient compliance, address missed opportunities to improve healthcare, address patient satisfaction, decrease 30-day readmission rates, decrease return visits for the same complaint, and that could be within the ED or the urgent care, decrease ED visits, and increase profit in the urgent care. Review of literature, and I apologize, this is a busy slide, but this was the best way I can present the information to you with it making the best sense. So the relevant themes of my review of literature were patient satisfaction, patient compliance, and lack of standardized tools to check on patients. The search history revealed 27 databases between the years of 2015 and 2023, which terms we used were compliance, satisfaction, urgent care, post-discharge calls, and those gave me 480 articles, of which 10 articles were found to be useful, and these were, as I listed them here on this slide. Literature critique. So the strengths of these 10 articles were that they all met the IRB regulations and approval. Most had large samples, some with over 20,000 participants. I believe Siddiqui et al. Was one of them. They all had inpatient post-discharge calls and outpatient calls. I really focused on the outpatient calls, but I had great studies that showed inpatient calls were just as useful, especially in patients with chronic diseases. Weaknesses, only 2 had small samples, like maybe 50 patients or so. Some gaps that I noted were no consistent screening tools, no article provided the patient education level, which could add to the reason for the failure or achievement of the post-discharge phone call. And then limitation, one article had 80 patients spread over 220 miles in the Midwestern states, but no states were mentioned. No socioeconomic status was mentioned, and one study was noted to be observational. The theory that I used for my theoretical framework was the Pettigrew and Whip theory, which actually started in the business sector. It later evolved into the healthcare environment in the 1980s. It stressed the dimension of content, context, and process or change. The underpinnings of this DMP project also took away the historical, cultural, and political factors that were instrumental in carrying out this project. The project's success is crucial in creating a culture of support and good communication, which the Pettigrew and Whip theory had over and over spoken about in their writings, that you need to communicate well. And part of the post-discharge phone call is, of course, communication. So business-oriented first and then outcome-oriented later. Business relies on 2 ideals: the ability of the business to understand its competitors and the competence of a business to assemble and manage the resources necessary to grow. You have to look around and see what other businesses are doing and what they're doing. And no other business was doing post-discharge calls. There are many urgent cares that I know, and I have friends that I work in, and no one was doing this. So I said, let's do it. The business of caring is still a business and must utilize tools in order to survive. I mean, let's look at it. It's still a profit that we still need to work in a business of caring. Methods. The DMP Scholarship Project was conducted at an urgent care in Central Florida. The DMP project studied the local population seen within the urgent care. The participants were selected using an EMR based on the inclusion and exclusion criteria. And studies revealed that 12% decrease in the odds of having a return visit, which is an odds ratio of 0.88, which is quite a large amount of people if you think about it. If you see about 40 patients per day, that's quite a chunk of your patients coming back saying, hey, I don't know what's going on. 45% of patients in these telephone survey studies said that they would take their prescribed medications as recommended. Now, again, this was not my study, but the studies that I took away from the articles that were chosen. Post-urgent care's compassionate time for the patient, as they may not remember what was taught or said during the visit. Again, remember, the patient is sick and not always is able to remember what was said to them, or what the care is of the wound and such. A timely follow-up ensures that tests, referrals, laboratory data, and other questions are properly answered, increasing awareness of the disease process. Methods continued. A quantitative correlation design was utilized through retrospective chart review within days of the participant's visit. IRB was obtained and identified potential patients. Consent was obtained. A screening tool was used to indicate the patient's preference for the time of day of the call. And we talked about this early on with Appendix A. A follow-up phone call was made within 24 to 72 hours of the patient's preferred time and day. A follow-up phone call was locked into the Excel spreadsheet, and interventions during the call, such as clarifying medications, follow-up care, and anything else, were made as adjuncts to their visit. Now, sample. The inclusion criteria, the patient had to be between 18 and 89 years of age, was able to complete a consent form and agree to the phone call, was able to read and understand English without a translator. The clinic that I work at does not have a JCO certification, so we did not require a translator for any type of language other than English. The patient had to be diagnosed with a condition that did not require transfer from the urgent care to another facility, meaning like an active stroke or a heart attack, had been diagnosed with a condition that required a medical treatment plan that was appropriate to the urgent care, meaning a strep throat, an ear infection, a laceration, or an abscess. The exclusion criteria was anyone over 90 years of age or older, or 17 years of age or younger, have a disease that requires more than interventions that an urgent care can provide. So again, something like a heart attack or a stroke. Any patient diagnosed with neurodevelopmental disorder or neuropsychological disorder, such as dementia or autism, no matter what the complaint or concern. Non-English speaking patients requiring a translator. So again, as mentioned earlier, we were not able to include those patients. Be a former current or former employee of the urgent care. Again, we didn't want any bias. And a Florida DOT, Department of Transportation physicals, or any governmental physicals were allowed. Analysis. So the data acquired during the program was examined through a retrospective EMR review over 2 weeks, starting on April 1st, ending on April 13th, about April 13th. The data collected a yes and no answers to satisfaction and compliance, and a U was used and assigned to the patient who was unreachable after 3 attempts. Then the responses were recorded quantitatively on a Microsoft Excel spreadsheet. A 1 proportion z-test was helpful in this as the project compared 1 proportion and tested the difference between the proportions that are equal to 0 or not. If the computed p-value is lower than the significance, then one should reject the null hypothesis and accept the research hypothesis. So these are my results. So this is satisfaction by gender. The next slide will be compliance by gender. So the interpretation of chart 1 is a little can be a little confusing, but actually it's not. All of that it really is saying is the p-value of 0.1265 is not less than the significance of 0.005. So there's insufficient information to suggest that satisfaction ratio is higher for males than females. The achieved power of the study is 0.896, which is also not considered strong. I had a total of 49 males, which you can see those are in blue, and females are in red, and the total population was 120. As you can see, that females were generally more satisfied than males, and also more unsatisfied and more reachable. Chart 1 shows the effect size of 0.57, which is actually a small size, which tells the author how far I had to observe the hypothesis ratio from the ratio of 0.75. So the effect size is actually something that measures 2 variables or 2 groups. The smaller the size could be 0.3 or 0.4. Usually that's a small size. 0.7 could be moderate, and 0.9 is actually large. So just by knowing the effect size and the p-value, you can actually make a conclusion about what your results are telling you. So really, this is just saying there's no really correlation between gender on satisfaction. Chart 2 is pretty much telling you the same thing. There is, no correlation between the two. The chart 2 shows the effect size of 0.0428571, which is a very small effect size. There's no correlation of compliance between the two genders. Now, when we go to satisfaction and compliance, the green you see is satisfaction, and the red is no satisfaction, and compliance is in green. And again, the red is non-compliance. So the p-value less than 0.001 is less than the significance level of 0.5. There is sufficient information to suggest that compliance ratio is greater than 0.75. The chief power of the study is 1.0000, which is considered strong. Chart 3 shows an effect size of 0.975. Now we know this because we know that 0.9 is a large number. Chart 4 shows the effect size. So chart 4 is our compliance chart, shows the size of 0.97435. In charts 3 and 4, there's sufficient information suggests that the satisfaction compliance ratio is more significant than 0.75. This is another chart that I did for Medicare eligibility. So anyone that had insurance that was over 65 and then primary insurance was Medicare, I did a chart that showed statistical analysis. The p-value of 0.0901 is not less than the significance value of 0.05. So already that is already telling us that this is not statistically significant. No sufficient information suggests that satisfaction ratio is higher for non-Medicare eligible patients versus versus Medicare eligible patients. The chief power of the study is 0.25967775, which is not considered strong. The study could be treated as an exploratory study to determine an adequate sample size for future studies. So if we're considering that, in that case, we have a power of 0.8 and an effect size of 6%, which is medium. A sample size of 460 patients would be required. The study output could be helpful information in future studies if anybody is interested of doing a study on Medicare eligibility and post-discharge calls. So the results continued. I just want to summarize what we found in these charts. Gender has no statistical significance on outcomes. Satisfaction and compliance has statistically significant outcomes from the calls. Patients who had Medicare as their primary insurance also did not have statistically significant insurance, did not have statistically significant results, and there were no opportunities for bigger studies to take place in the area. Discussion. So the next few slides are going to talk about discussion. Post-discharge phone calls should always follow any visit or contact with the patient or in any outpatient setting. Ambulatory care, outpatient care, emergency department, and urgent care usually share the same theme: quick care and quick discharge instructions. The author's data provided statistical validity that the post-discharge calls and the urgent care made a difference in patient care. The author made the calls herself, which was a welcoming call to the patients. Now, some limitations were the results of the satisfaction and compliance may have been skewed if the study population was more diverse. The site sees a lot of patients who are vacationers, we call them snowbirds here in Florida, and who live in middle to upper income families. There were no translation services available. No pregnant females were able to be seen, and that was the clinic's policy. And Medicaid was not accepted at the urgent care. Again, this was something that the clinic did not want to have as an insurance. Implications for practice. All settings need a formal follow-up process for the patient. Research shows that post-discharge calls have been made to decrease ED visits, 30-day readmission rates, and morbidity and mortality rates. Thus far, no agency has made follow-up mandatory calls in any settings. It is not federally or state mandated. It's actually facility driven. A standardized tool works best. All patient populations need to be included in these studies. However, it is noted that some organizations in areas where not all populations can be represented, such as in my area. Only 18% of all DNP projects have sustainability plan. Continuing the phone calls post-discharge project and ensuring the team is following the suit is critical. Engage stakeholders in the plan, such as the president, your supervisors, and any ancillary staff. Summary and conclusion. Include more heterogeneity in your future research. Partner with stakeholders in your organization to start a program that would sustain these outcomes. Join local organizations and continue to stay in touch with your chairperson. I know that I will. More studies can be built on this study. Consider publishing any work with good rigor and statistically significant results. The DNP research project was statistically significant and accomplished the goals that it set. Thank you so much for taking your time out of your busy schedules to listen to me talk about post-discharge phone calls. I welcome any questions, and I am so proud to be part of this graduating class. I congratulate every one of you on such hard work and a journey that was more difficult, at times unbearable, and at times almost not thinking that we could complete this. So thank you so much for everybody's support. Dr. Elby, you are my hero. I have 15 slides with APA with correct APA. So I'm just going to go through them quickly because we're running out of time. But again, thank you so much, and I welcome any questions.